Good afternoon, everybody. Welcome to our latest series on the 10-year plan. We will be focusing on the single patient record today. We have another stellar panel lineup from NHS England and across the health system. We have got a lot of registrations and I've just seen about 30 people just joined. So I'm just going to give a few folks a minute just to join us, just to make sure their Teams is working. It's whitelisted, they're in a quiet booth or a microphone or headphones are working. Technology, hey, who would have thought it? Who works in technology? So after that, we'll do a quick intro, and then we're going to go straight into the session with the view on the single patient record. Then everyone will go through their views on various discussion points. The Q&A function doesn't work for this format on Teams. You can use the chat function. So if you've got a particular question or couldn't hear or got any problems, then the team can respond to that. And then I'll pick up questions to provide to people as we work through the kind of process. So we'll get a discussion going. And then as questions come in, I might throw a few of those out to the team, depending on how repeated they're asked and how important they are as we go through. So don't worry, I will try and get through as much as possible. We will record the webinar as usual, so if anybody needs that, anybody wants to follow up or any colleagues missing, we will publish it on the digitalhealth.net website post the event as soon as the copy is available. Once again, thank you to all our panel members for joining us today. I know life is busy, so it is much appreciated. And thank you everyone for joining us in the audience. So we're a couple of minutes in. I know people are still registering, but I'm going to kick off the proceedings. And Emma, while you've still got your voice, could I start with you to introduce yourself, please, Emma?
Yeah, hi, and I apologise if people can't really hear me. I'm Emma, I'm a physiotherapist. I am Chief Allied Health Professional and Nursing Information Officer for Norfolk Community Health and Care NHS Trust.
Thank you, Emma. Ian?
I'm Ian Anderson, the Director of Legal Services and Partnerships at Hull City Council and Senior Information Risk Officer at the Council, as well as a sponsor for the Changing Futures project.
Thank you, Ian. Basil?
Good afternoon, everyone. I'm Basil Bettis. I'm a paediatric surgeon by clinical background, which may not be familiar to most of the audience. I'm clinical safety officer at Sheffield Children's NHS Foundation Trust and do various other bits and pieces, including being on the CCO advisory panel with Lee.
So Ming, can I come to you, please?
Sure. Thanks, Carl. I'm Ming Tang. I'm the Interim Chief Digital and Information Officer for NHS England. I'm also the Chief Data and Analytics Officer for NHS England.
And finally, but not least, Lee, please.
Thanks, Carl. So yeah, Lee Rickles. I'm the Chief Information Officer at Humber Teaching NHS Foundation Trust. I'm also the Director for the Yorkshire Humber Care Record. I'm also a member of the CIU and the ICS advisory panels.
Thank you very much, everybody. So we'll be trotting through quite a bit of topic today, but to start with, I'd like to come to Ming just to set the vision from the centre on the single patient record. Thank you, Ming.
Thanks, Carl. So if I step back and say, what's the problem we're trying to solve? Because quite often we kind of dive into what it is. If you think about it in terms of, you know, the amount of stuff that NHS staff are trying to see and have access to in one place during the consultation, the time's quite short, you know, even if they're doing the ward rounds or even across different health settings. For all our health practitioners to have access to similar data, which is contextual to their role, is part of the problem with, you know, what we're trying to achieve. And when we did quite a lot of public deliberation, 65% of those patients that were asked said, you know, they have to repeat their story. And I know from personal experience, when my father was quite poorly, I used to carry around, you know, paper notes just so that you could make sure that they covered everything that was around them. So for complex cases, it's actually quite a burden on the individual to make sure that their story is heard. And then really, there's kind of a report that there are reports also that because of the difficulties in getting a longitudinal record across the piece, often we made diagnosis or we have missing information that the clinicians would have made a different choice. So that's a problem area that we're trying to solve. The vision is really to make sure that we are able to connect existing systems, be that APRs, shared care records and other platforms, so that clinicians and patients can have a view of their longitudinal record in a trusted way. And really, through the app, we allow patients to be able to surface their own record, the entirety of the record, not just the summary or the bits that the GPs allow them to see through their system. So it's getting a more consistent experience across the piece. What it isn't is a massive new platform that we're trying to stitch everything together. It's not a massive data lake. What we're really trying to do is federate, and a core capability will be about surfacing the right data for the right use case in context of the user. And what do I mean by that? If we are going to be moving care out of a particular setting into a more multidisciplinary team, then we will also need to engage with carers, domiciliary care and other local authorities, etc., at a neighbourhood level. How do we make sure that data is available and viewable in a way that's safe, that's as privacy managed, but actually does the best thing for the patients? We are intending to build out from the great learnings from the shared care record, and one of the kind of technical proofs that we're looking at is, can we federate shared care records? So we're not trying to build out a massive thing. I think there will be 4 or 5 missing components to the existing infrastructure that we have, which will just enhance the way that we see the data, the way that we use the data, and the way that we present it. The ambition is that with this orchestration layer that we're putting in, and the means by the technological means of doing that, we will then develop future use cases, which then are much more specific in terms of how that data is curated, how the data used from the care record is actually presented and allows other things to happen. So, for instance, a unified care plan between the patient and their carers, or between multidisciplinary teams for those frail elderly patients that are we'll be looking at a neighbourhood level. I'll stop there, Carl. Hopefully that's given you a bit of a view.
Super helpful. So just picking up a theme there around shared care records. Obviously, there's quite a lot of work that's been going on that. Previously, there was the Leica work, which was also pretty successful with some findings there. And Lee, this is a particular area that you're focused on and doing some work in your region. Obviously, the shared care record also has some dangers in terms of funding, attention, and just generally being a bit of a pain. So if this is potentially going to underpin some of the work that's happening on single patient record, where do you see the fit? Where do you see some things that need to be worked on in order for that to be achievable? Big question, I know.
So big question. I'll try and be brief, Carl, because I can talk for the whole hour on this one. I think you've made a key point on the funding and capability. As much as we've got a really good community on the shared care record community, there's some good technologies. It's really difficult to get the sustainability, especially in certain regions. It's one that's picked up very greatly in a number of them, where it's just really difficult to sustain, and it's actually quite difficult to resource and deploy the shared care record. Now, again, this could down to each particular shared care record of, is the focus on solving problems and improving quality, or is it around tech? So there is a little bit on the messaging on there. Realistically, the solutions that are out there are the solutions that are going to be around for a few more years easily. The challenge is actually, do the shared care record vendors step up to the mark and achieve the standards and capabilities they should already be delivering? Especially if you're looking at the need to use open standards to share information, use a separated data layer to get access to the information for second users and pop health, things that are where core components in the Lycra or in the connected care program. So in a lot of cases, although suppliers and vendors are providing them, there are gaps. So I think I see the single patient record as an opportunity to deal with a number of the issues we've got with shared care records. How do we make it sustainable? Because the current model doesn't have sustainability, otherwise it wouldn't come up at every meeting we have with the shared care record community. Get benefits for that size and efficiency, but also have something that joins in a more succinct way information and systems, because again, it's very fragmented. I mean, there's you know, when you're looking at something like GraphNet on Orion, or some of the other major players into systems, they are separate silos of data, not linked together, different standards, covering different populations, not sharing data, etc., etc. I think we need to be a little bit more ambitious on the shared care record. So one of the proof of concepts one is NRL. I am massively disappointed that the best we can achieve is sharing a PDF between shared care records community. That's not a technical limitation on the systems. So we this week as Interweave had to step back from full fire package sending, so fully structured data that then can be reused to the international patient summary to, can you just send us a PDF? Because we misinterpreted, from our spec, we misinterpreted that you're not just going to send us a PDF. So within 24 hours, we were there to solve it. But I think that's where we need to be a little bit more ambitious as a country, a little bit more forceful on actually we do need to do modern stuff. This is stuff that we're now trailing behind other countries. And it's not that hard. What it does require is good working together, transparent honesty and trust, and clear leadership and direction. And I think that's where I see the shared care record community continues working with where we have been with the connected care team, the single patient record team, because we have been involved in the proof of concept work as a community. They're briefing us, they keep us in the loop as that side of thing. There's a real opportunity to do something quite special. The risk is it all goes pear-shaped and we go to a PDF version, which is really an absolute failure, definitely from our perspective. And the reality is when you look at a PDF as a PDF, that's fine. PDF for a paramedic who's now having to check 47 PDFs because that's all that's available, never going to happen. Be completely ignored, not user-friendly, not useful. And I think that's coming back to the point that Ming mentioned. Why are we doing it? What's the problems we're trying to solve? And it's not the same problem for everybody. A patient, a carer, a professional all have different requirements. So it's just been sensible, but accepting we can't support all them requirements in one go. So I'm quite positive on it. I'm not saying all the community's quite positive, but I'm more engaged. I'm more linked into what's going on. But we've got to do something else because this current shared care record setup is not sustainable. If we carry on the way we're doing, we're just going to end up, it'll start withering on the vine because, you know, and that comes down to regions and ICSs depending on where they are.
No, I think it's really important. I think one of the things that is often said within the NHS is often good pilots, good systems, good blueprinting starts, but then it doesn't scale and it disappears and the lessons are lost. So let's hope they don't. Right, Ian, I'd like to come to you from a local government perspective, particularly sticking with the themes around standards for a moment, and then we'll circle back on some other comments. So just in terms of how it works, obviously local governments often got different care systems, different care noting system, different software, but also different kind of governance, different management perspectives as well.
Yeah, I mean, I think going back to these points about fire and the utilization of standards, one of the key things has been understanding how data is stored and in what form, obviously SNOMED codes, and how that links to what we utilize so that those integrations are more easily achieved, and to avoid system to system integrations, because if you go from one provider system to another, you're missing the trick really. So we've built a Fire Gateway as a subscriber and provider of data to enable us to pass different forms of data from the social care perspective in particular to start with, but for me much more wider than that, because we have much more capabilities than social care. So the key thing in context of the question you've asked is sharing and understanding how data is utilised in the NHS and recognising the value that local authority can bring. And when you're talking about the single patient record, not thinking this is solely about health data. It's also shared this data from across the system, and that includes the voluntary sector. Now, the mechanism through which we get voluntary sector data in presently is through utilising health systems, but obviously they have systems as well. Common gateways in helps us overcome the problem. The value also of partnership working is around understanding the use cases within different environments and how they impact on what is happening in the NHS. The most obvious example that Lee and I are familiar with is a medical examiner, where we have brought in legislation requiring medical examiners to be brought in and to work with in place of the coroner, but all the records closed at the point of death. So the way that the medical examiners had to access community-wide files was by people travelling around the city, getting the files together, bringing them into the centre so that they could be looked at. And of course, people are focused on a cremation date, and if that, then we had one situation where a cremation was imminent on the same day, and we had to run around to get the thing sorted to stop the cremation being prevented. And it's understanding those impacts. So we've overcome that. So we have achieved medical examiner access to facilitate that, but it's understanding it's not just a health system live per patient model. You're looking at a relationship that takes in many different stakeholders, and you must always have that in mind. Going back to briefly to Ming's point, providing information to aid other parts of the system, one of the key aspects is about me for me. Trying to get that into the system, so where we have information about a patient or a potential patient that will help manage that patient, changing futures is where I'm focused, particularly people who are not necessarily going to be the most welcome in A&E. How you provide good information to help that person be managed reduces some of the need to deal with things in other ways, let's say. So that we've got to have a whole system approach.
Thank you, Ian. Very insightful, and just delivers the point that we're not just talking about a patient presenting at A&E here. Basil, could I just extend that a little bit further for you, with also bringing in clinical safety standards as part of this, and where the kind of buck rests and where you get security around potential implementation of single patient record?
Thank you. I'll just say I sort of always wonder why I'm in these places, partly because I want to be around that specific question. So I guess the key thing there will be, and this has been borne out by experience of trying to implement the access to shared care records, is the very thorny issue of liability. And I think this is one of many foundational problems we really haven't actually tackled. It's being left as an afterthought, as regulation and compliance often is. People familiar with the area will know that the clinical safety regulation has been around for a long time, and it's well recognised that we haven't quite delivered the statutory requirements around that, let alone anything new. The AI era is really problematic. It's running away, and we haven't really, developed things to cater for that. The liability thing, to specifically focus on that, I think is very important. I have to represent the clinical safety needs of a large organisation, large in the sense of its reach, but not in terms of its size. Community care, transport, and children's services, both local and specialist. So what you see there is that you are providing quite disparate services to a very wide range of staff, who are then being given access to information without a clear steer on what their expectations on them are. If you provide access, does that require to know everything that is within the system you have access to? And we've had difficult discussions about how to make that clear, how to handle it. And from my point of view, agreeing upfront and a priori what happens when things go wrong. So I think that is a critical point about the single patient record programme and shared care records in general, as well as just the useful and liberal access to information as clinicians, which is, as we may come on to, relatively unstructured, not truly interoperable, and not forming a common meaning for individual patients. So I would say those are kind of key questions that ideally we would have worked out before we started any of this, because when it goes wrong, I fear we'll have a sort of pointing finger situation where organisations start to say it's your fault, not ours, because we haven't agreed how to collectively respond to harm. And that never looks good, whether it's a clinical incident or a data-related incident.
Basil, really, really important points there, and I think there is an awful lot of work that needs to be done there. I've been privileged to be on quite a few of these and spoken to Ming a few times, and there is a central piece of architecture that is being worked on, which is going to deal with some of this, but there are always kind of grey areas on the edges. Emma, I'd like to come to you, just extending on Basil's point there, but also in terms of patient access. And someone working in between kind of various different people, between kind of patients and clinicians and administrative. Where does single patient record fit for you around that kind of standards and access and changes of working?
I think a lot of the challenges are the same as with shared care record. I can see in the chat some people have asked around real case scenarios. So I will talk from a very different point of view. I'll talk as a clinician in a real life situation, being out in a patient's home, being told I was there to see them for mobility, the patient then lifting their pillow and saying, check out all this medication. And there was a lot and it was hardcore. I'm going to be taking all of that when you leave because I'm not happy. There were significant mental health challenges with this patient. I spent 4 days trying to find the right mental health team to be able to have that discussion, and being really quite scared as a clinician about how I could manage this. When I finally got hold of the mental health team, they knew this patient. They knew what their triggers were. They knew what their behaviours were. If I had been able to see some of that documentation, I would have been able to have had a much better clinical interaction. I wouldn't have spent 4 days thinking, oh my goodness, I've got a patient who is going to do something very significant when I finish. So where this works is it gives us as clinicians the power to see what else is going on with this patient. But there's a challenge that comes with that, coming back to Lee's point about generating 47 PDFs. Actually, if you've got everything in one place, filtering it to find it is actually quite challenging because you've got so many other people's clinical voices in it. So for me, I think the challenge is how we use that information and find that information in the right way. There's a big challenge back to clinicians actually that means they actually do need to read other people's documentation. Actually, as a clinician, your documentation needs to be readable. And when I say that, obviously, if we're typing, it's legible, but actually, if what you're putting in is clinically not helpful, you are putting in stuff that other clinicians have got to wade through to find the relevant piece. So I think there's also something within this around documentation in general and how clinicians do document, do use documentation, and do listen to other clinical voices within that documentation.
Thank you, Emma. I think there is a whole minefield here, which I won't even make any further comments on. Ming, I'm gonna come back to you. I know there's probably a couple of points you want to come back on, but also just in terms of the comment you made earlier about furnishing data or access to certain data. What's the vision for what data will be pulled and how that will be managed at a central level rather than at the centre?
Yeah, there's 2 ways you can look at this. Some people are saying, "Oh gosh, why are you taking so long? It's not so difficult because we've done it all with shared care records." The reason we're taking our time is actually to understand what problems are we trying to solve, what's the best way to do it so that and to be clear, we're not going to do it all in one big bang, right? It's not going to be done once and done. There will be infrastructure that we'll be building that then allows a much more open way of curating that data for specific use cases. And we'll probably launch a few use cases at a time. But the whole idea, what I was saying to the team the other day, is I want this to be a set of Lego bricks that you can build what you need, but in a safe way. And the use cases will drive the curation and what you bring forward in that data. But we want the data to be near real time. We need it to be configurable. We need to understand what language we use to create that data to bring it forward. So I don't think this is, and there will be an element of AI in this that we will need to test as well. So because, as Emma said, most clinicians only manage to read a little bit of the record, even the clinical record, when you have majority of the stuff that's happened to someone, because they just don't have the time. So as part of this, side by side this, we need to use the use cases that then drive actually what's the assistive technology that we need to put alongside it to make it easier, and that we're bringing up the right information for the patient. How do we work with the NHS app team so the patients see the bits that they want? In the public deliberations that we've done, there was a question in the chat. We've done quite a lot of public deliberation, and there are huge benefits for patients that they can see. They also have some red lines that we're working through. They want to be able to have a lot more granularity on who sees what, but they don't want to have all the decisions as tick boxes, so that it makes it really complicated. So there's a bit of us moving into the real world of near real time, which means that in the context of what you're using that data for, there may be some questions we ask the public. What do you want? What are you comfortable we share X, Y, Z? So that's why we're taking our time. The politicians are obviously anxious and want us to get there a bit quicker. We are taking our time, and hopefully, as we explore both internally, building on what investments we've made so far, because we can't afford to throw away everything that we've done. There'll be a journey where we look at a roadmap that we switch some things out over time as the technology changes. So we are trying to be quite considered. It does mean that we don't have clear, distinct answers to all these questions, because actually we're still trying to curate some of it so that it makes sense in the context that we're trying to do.
Thank you, Ming. There's a couple of questions, but I'm going to come to Basil first, as you've got your hand up.
I could ask a couple of questions. I mean, I guess one of the things I would put out there, so I was chairing a panel at Let's Talk Digital a couple of weeks ago, and there's a very fundamental question, which it sounds like we're all agreeing about what the purpose of this is high level. So this is for direct and individual patient care. I might be wrong in that interpretation, but I don't think us as a clinical and professional community delivering these services necessarily agree on that being the top priority. And we talked a little bit in our pre-meet about being soldiers of fortune in our many various roles, where we can see problems. I talk to people in industry and academia, people in the NHS central teams. I was talking to someone from the NHS app team this morning about results release, and they're always wanting to do things they're not allowed to do. I kind of wonder where can some of us get in the room with those politicians and ask them what they're actually after? Because I still think that the rhetoric is around secondary uses. It's public health, it's operational management, it's research, not individual patient care. And I know, Ming, you found the language around potentially problematic because of what people interpret that as meaning. And I think that's important. And I don't think the clinical professionals agree, because there are lots of vested interests about what we want out of the data. I spent my whole career in a very niche area that is not well catered for technologically because it's small volume. And that's getting harder and harder because big data, AI, require large volumes of data for what is our critical universal community of children and young people that are the universal group that everybody has to go through. So my first question would always be, let's set the hierarchy of priorities for what the outputs are, not these problem use cases. I completely understand the need for problem solving and delivery for real world actual problems, but I think that plays into the legacy we have already of things that built us the way they were for the purposes originally intended. They're not around single individual care and data recording. So I asked that question. I think the panel agree, but actually in terms of what we're going to be doing in the next few years, there doesn't feel like, because I keep asking, a place where that can happen without an immediate delivery priority. So I wonder what your thoughts might be on that, anybody?
Yeah, so in my priorities, the single patient record is an enabler, but whatever we curate in that and make available through that will be made available for research as well. So it's how we convert what we're doing in single patient record into a persisted record. That's a dilemma we're trying to work through at the moment, Basil. And I'm being really honest about it, because I don't want everyone to then jump, oh my God, she's going to create this massive data lake. So we do need to do it carefully. We do need to, but technology is actually moving on. With some of the things that we're doing with Open Safely, we can see that we can federate queries without actually bringing everything together. So we need to do that piece of work. That's why I'm not coming out and saying it definitely is, but it is in the priority list. And for population health and for risk stratification, all those things, absolutely, we want those flags, because we're building in the requirements for surfacing some of the genomics characteristics in the record as well. So for rare diseases, I think that will be quite a move forward as well.
Thank you.
Carl,
Thank
can we
you.
wait?
Okay,
Is it
one
okay,
second, Baz,
just
because
on that?
Lee's been
Okay.
waiting. Let me bring in Lee and I'll come back to you. Okay, thanks, Lee.
Yeah, thanks, Carl. So I'm just going to bring us back to a couple of things. We haven't cracked it on shared care records, LICRA, and hopefully we will crack it on single patient record. The real reason we're doing this is we don't want another Victoria Columbier, Baby P, or even a Harold Shipman. And the Harold Shipman does require us to look at wider data sets than just direct care. Let's be honest, he's the biggest murderer ever. And that was down to data to track that there was a problem there. We've got to look at it from that lens. When I go to coroner's court, I've never been to one yet where we had an issue that more information's been shared that would have caused that death. It normally comes down to information not being shared by some professional for some pseudo-legal reason that has caused a death or harm to patients. So we need to take them points into account and make sure the professionalism, the safety controls, even the how we manage liabilities is taken into account. Otherwise, we will never move on from the current position that we'll never we'll never end up with a system that prevents that risk. And the final part, just to close off, is this all requires a significant change to how people are providing care in their practice. Systems are already out there, but what we haven't done is crack the point that Basil made, where we haven't changed practice, and it hasn't necessarily meant that the information is either being useful or even acting on. And I am speaking from personal experience 2 weeks ago, where I was in ED with my mum, and they have access to all this information, but they still refuse to look at the system because they want to see the paper prescription. Who has a paper prescription these days? It's all electronic. Obviously, people in ED and the acutes, and also then having to go through a long drawn out process when everything was on the machine that was next to the consultant that was stood there. So, you know, there's a few things in there. So although we're focused on the technology, there's a massive bit on change of practice and how we operate. If we don't click that one, we'll just spend a load of money on tech and it'll be a waste of time. So I'll close off at that one, Cal.
Thank you, Lee. Basil, you wanted to come in quickly before Ming. Sorry.
If that's okay. I mean, I guess I'm very familiar with Open Safely, secure data providers, all the rest. I'm going to say from frontline clinical perspective and the needs of things that are not well catered for by large data sets, I think those things are skewing some priorities. I'm not suggesting any of that stops. I'm not suggesting we don't do for the here and now. There is a great need to look at problems without being bound to anything from my point of view. I've always suggested the domain of the new person, the newly born child, not as a specific area you need to cater for as in the 0 to 5 programme, which does exist within the HSAP programme, or under the privilege of the College of Paediatrics, but as a place where there is no legacy data, where you are dealing with fresh problems and where actually the majority of all needs for the entirety of your life must be handled within the data structure. That's my suggestion for getting out of the problem of not being able to think freely about how you design things, because research priorities are very different. And I take Lee's point about the broader picture, but actually my contention, I may be wrong about it, is always that if our information systems can only allow for one person to get good quality care, share all that information, present it really nicely in a user-friendly format with a good UI for the end users to see what they want, act on it, and it does nothing else, I would be okay with that. And I say that not because I think that's all I want, because I know if we did that, we would get the secondary outputs in a far better form than they currently exist. The reason I say that is that the quality of the data depends on the professionals that understand the domains they work in to record information in a way that is realistically representing reality. And we all know the data quality in our existing information systems is really bad. My fear is that big data and AI approaches will mask the poor data quality. They will give us really precise and really inaccurate outputs that are going to be wrong all of the time, rather than an obviously wide confidence interval. That is the risk we're running, I think, from a non-data scientist perspective, but someone who's tried to get data for the things I'm clinically interested in, which is why I think we need to have a space that is totally parallel to all of this talk in some ways, to let some people at low cost talk and think about it. And they're out there, but they're doing it unsupported, without the politicians, the strategists actually listening to them. And I would include everybody here, including you, Ming, about wanting to maybe do some of that stuff, but not being allowed to do it. I'll leave it there and hand back to.
And I think it's something we should take offline, Basil, because I don't think we're at odds at all, right? So the whole data model that we're putting in is, I've asked the guys to look at it through a lens of life course with that exact view. And don't forget, we're living in a legacy of data is collected by service, not by person, right? So a lot of the data science trickery that we're having to do is because you can't actually look at a distinct pathway for a person with the data that we have, because it wasn't cut that way, it wasn't collected that way, okay? And it doesn't have those standards in that way to make it easy. But we're talking about how do we build from what we've got so that we don't throw away everything, but build it without some of those constraints that you're talking about. And the bit I forgot to say earlier on is there will be legislation to support single patient record, which will give us a legal basis for both the primary uses and the secondary care uses, the secondary uses of that data. So that's but within that, we still have the, I still have the accountability of making sure that we're not abusing that. You know, so there will be changes in the way that data controllership and all those things are managed to give us the ability to use the data in real time, but also for those additional uses that you're talking about.
Emma, I'm going to come to you, but I just want to also add, just in terms of the practicalities of what this looks like and how it works. The NHS app was mentioned by Ming earlier. Where is data going to be? What's the issue with the app and information coming out on the app versus the management of that information by the clinician? What works? But Emma, I'll pass over to you, please.
Oh, I wasn't going to talk about NHS app. I was going to come back to it.
If you finish your point, then we can move on to that second point as well.
So I was just going to build on top of Lee's points. Oliver McGowan is all I'm going to say around clinicians having data, having information, and not listening. And again, there is that clinical practice part within all of this that we need to remember, and how we get our clinicians to read and understand notes. And actually coming back to some of the stuff that Basil was saying about quality of data, again, quality of documentation, input. There was something else in my head and it's gone. What I was going to ask Ming, and actually it's probably a question to come back to because we want to move on to the NHS app part, is what does solving the problem look like? You've articulated the problem well about single patient record, shared care record. Actually, what do we think not having the problem, solving the problem looks like? That might also help get us into a place where we're on board with getting it there because we know what the outcome looks like.
For me, it's almost seamless, right? So, and don't forget, this programme came out of the 10-year plan, so we're not really delivering just for the next 3 years, we're delivering for the longer term. And in the longer term, we would expect that wherever someone presents, whoever needs that information, they have it in front of them, right? And the person also understands. So what good looks like is if you've got multiple long-term conditions or a single long-term condition, you'll be able to see your record, you'll be able to see and understand jointly with your clinician the care plan that you have, the information you have. That's kind of why it links into the NHS app, because we'll be surfacing a lot of that through the NHS app. For clinicians, they'll be able to do their day-to-day job. For populations, we'll be able to plan and forecast and predict. So that information becomes a layer, almost a separate layer, that allows us to then apply new technologies, do the predictive work that Basil's looking for, do the search. You know, if your patients, it's about giving some agency back to patients as well. If they want to participate in clinical trials or they want to understand more, they know, yeah, there's enough flags in that record to allow them to present that without drowning them. So there's a whole load of things that we would want to build on top over time, but we're really starting towards just bringing it together, understanding what's possible in bringing the data that we have together. Over time, we'll change some of the standards so that it flows much more in an events-based way, that I can see services subscribing to the single patient record so that they can use that information to enhance their own individual services, which will then allow them to be much more proactive. So much bigger ecosystem around the patient journey and characteristics of that person.
So on that, if Basil wants to look at other work done by people similar to himself in other hospitals, would he potentially be able to access the single patient record to look at that information rather than read-write access, as it were?
Yeah.
Okay, fine, perfect. And just building on that question, I think one of the things that people are still struggling with, and I mean, you've repeated several times, this is going to be a modular approach, we'll add things, it's not a big bang platform. There's been discussions previously about, we'll start with maternity, the Red Book program that had started and then unfortunately stopped. There's also end of life care, which has been done quite well in the Northeast and in the One London project. What can we kind of like using as both clinicians and patients over the next 3 years, let's say, rather than 10?
Yeah, so definitely maternity, probably frailty or vulnerable people in the community. So this will then bring in how are we working more in a neighbourhood way, a multidisciplinary way, and it then really flavours it as to what are some of those subscription services that other people can use to enhance their local service. And end of life would be part of that, those vulnerable people. Yeah. So the reason why we want to do maternity, because that then allows us to do what Basil was talking about, thinking through a child with no records at all. How do we then make that, clean that out and make it flow in the way that we want in the future?
So Emma, I just wanted to come back to you on that in terms of the patient app and the single patient record and shared care, your own EPR system, your own notes. Not everything filters down to a paramedic, for instance. I know you're not a paramedic, but are responsible for kind of AHPs, and paramedics often say, this is great, but I don't have access to the shared care record. So what do I do? Just at that kind of coalface, just what's making sense here for you?
I think that ambition makes sense. What I still see as a challenge is we don't have everybody on an EPR. We don't, even some of our trusts where we are on EPRs, we haven't got everything pulling and pushing out of a shared care record, let alone going into a single patient record. If we think about the NHS app, it's the same thing where we haven't got every single NHS organisation's stuff going into the NHS app. If I think about that as a clinician talking to a patient, again, there's some challenges with the NHS app that actually what the patient sees is controlled at GP level. So when you're talking to patients, you have to really be aware of what you can't, as a clinician, you can't possibly know what different GP practice surgeries have and haven't enabled with the NHS app to be able to talk about it in that way. So there's a lot that resonates as a clinician of, and I'm quite relieved to hear there's, how do we filter it so we're not swamping our clinicians with data, with information, so that actually the clinician can get to the right information at the right time. And actually sometimes you don't know what you need until you're in that patient house, in that patient environment, in patient community, wherever it is. So that being able to use it flexibly and in different ways depending on the environment and the situation you're in fills me with joy. I think the fact we know we haven't got everything filtering through and how we get that is, for me, still quite a big part of the challenge.
So thank you, Ming. I just want to build on what Emma's saying there. So there are multiple supplier organisations that supply GP data and access and booking services. Some don't have any of that at all. Ian, on our briefing call earlier, mentioned about using the pupil number for recognition. I'm just want to go in a level deeper than we've discussed now about how we get access to this data, how it's going to be provisioned, and how we make sure it's secure and got the right standards.
Yeah, so I think some of this will be changing the architecture quite significantly to do that, and that includes, as I said, the legal basis for us to share that data. There's also the data use and access bill, which we'll be using to enforce interoperability standards. And then there's a whole load of change management. So, you know, the whole app, the technology switched on, but GPs haven't switched it on their side. So there's quite a lot of change management that we need to do in the system to get that to work. We've got variation, not because of the technology, we've got a lot of variation often because of we haven't actually changed the processes. So part of the whole 10-year plan work is to figure those things out and then work through those programs. In the investment profile that we've put in 50% of the money to do the change. That's quite a big change from how we've invested in the past, just so that we can, I would prefer to do less and adopt more than the other way around. At the moment, sometimes we go out and it's spread quite thinly, and then we wonder why we don't get the benefits. So we are changing tact on the way that we do some of these things. I think, hey, it's not easy. If it was easy, we would have done it, right? We had many years on the shared care records and other things. It isn't easy. A lot of it is people having to give up some of their agency as organisations in order to be part of the whole. Some of it is us in the centre not wanting to control everything and actually making the architecture so other people can plug and play, so that they can use the core structure, core services, but it's actually much more consistent as a pattern, but allows people to get on with the use cases that are really important to them locally. So that's all part of the consideration of how do we do it like that.
I mean, Ian?
Yes, a couple of points. I think the reference to neighbourhood support, people in community and such like it leads me to sort of make the point that those who have contact and have the need to rely on the information about how to support a person with their health needs are often not the clinicians, and the clinicians may only be with the patient for a very small part of time compared to someone going in twice a day to see that person, support them. And so it is really important to look at the whole package, and that, as I've said before, includes voluntary sectors. Now, obviously it's not possible to make information available, but all that it sounds is going to be covered by the legislation. The other point to mention is we need to be careful with the focus on digital about not exacerbating health inequalities. Many people in certainly the area where I work presently have reduced means, minimal needs, and in those areas of deprivation, if you rely on mobile phones, then people have old phones if they have those phones, and they don't pay for subscription services, they rely on free to use data. One has to look at the wider potential for how you make that possible for people so that they don't miss out. So one thing we did when we tendered our concession contract for free Wi-Fi was put a garden wall around it and say any use of council sites must be continuous and not limited by time, so the 30% minimal. And obviously if you look at that in the wider picture, you would say, well, you need to feed into those discussions so that the local authorities understand the importance of putting a garden wall so as to facilitate the NHS app at all times free to use, where they're enabling free Wi-Fi. But that takes you much outside the health system into territory that those discussions usually don't enter into, because otherwise health inequalities become exacerbated by access to the methodologies that we rely on. And if we're talking about the the outcomes overall, how we help people to manage their own care, to improve those outcomes, how we manage outpatient support, all being related to a digital interface. You've got to make sure that all works and they have that access, and it's possible to use that in a manner that is consistent with the circumstances people live in.
Thank you. Just quickly to Basil and then over to Ming.
I just echo that point about vulnerability and inadequacy of access, because this morning the research call I was on was about the release of results on the NHS app and the negative incidents about how that has happened for some patients. I think, and this is a difficult thing to be saying, but there is an element of paternalism, not an individual, that is required here, which is about protecting those that can't speak for themselves. I will say that and defend myself by the role I have. I work in paediatrics. My primary role is to the child, who mostly does not have full agency. And I'm allowed to be paternalistic. I'm allowed to override the parents appropriately for their benefit. It's become unpopular to be like that as a professional, quite rightly, because of the history of the professions and how they address the individual. However, if you're going to prioritise releasing results to motivated groups of people with chronic illness that are educated, have apps, have data, then you will neglect those that have no apps, that are vulnerable, that are going to be missed. And I think you need to reflect on what you're trying to achieve with the aims and set the priorities on that basis, which is difficult because you then have to tackle the disquiet and unease of vocal people that might challenge that. I don't know the right answer or the balance, but I think there is an element to do that. Yeah,
it's a good point. We're running out of time, so I'm going to cut people off and move on quickly. Ming?
Yeah, so all of those things are really difficult conversations, aren't they? They're quite difficult. I would say that by the app and some of these things that we're looking at, by looking after the majority then frees up the time for the minority. That's one thing. Second thing is we are negotiating with mobile phone providers and telecom providers. Any use of the NHS app is actually free from a data perspective. So that's actually a really good piece of work the app team are doing to reduce the inequalities of that. And that is thinking out the box, as is the stuff they're doing in libraries to teach people how to use the app. The other thing that we're looking at is making sure the language is multi-language. It's not multi-language at the moment, and that's one of the things I'm really passionate about. And then if you actually look at the analysis of the app, a lot of people go on to the app for some of their things at the weekends or in the evenings. It does seem like they've got family or people that are helping them use, certain parts of the population, which is given that support. And definitely in some of the user research that we've done, in fact, there've been some quite pointed conversations back to the teams that we are patronising people, that they do have smartphones, even though they may not have a lot of money. They prioritise that because it's just part of normal living. So sometimes we kind of need to look across all things. But the most important thing for me is separating the concerns so that we can spend more time with those that need it, that don't have those facilities, by dealing with the larger volume through the other means.
Thank you, Ming. I'm going to ask a next question for you. I'm going to then come to you, Emma, just on that particular point there in terms of access and authority and the legal connotations. At the moment, there's not a possibility within the NHS app or potential single patient record for me to assign my care to somebody else without going through a legal framework. Is that being looked at and considered as part of the change and win here? And what does that look like?
So I think they've already enabled proxy access in the app. So I think if you've got proxy access to your patient record through your GP, that carries over to the app. You can actually enable it through the app. So it's not quite as legalistic as you're saying, but it is with the consent and agreement with the practice, if that makes sense.
You mean, Emma?
Building on Basil's point, and I guess for me, it's how we make this patient-centric in a way that really is patient-centered. We have patients who want to see data. We have patients who don't want to see data. And how do we get this into a place where we can do that? When stuff was on paper, we would have those conversations with our patients to say, how do you want this? Do you want to be have this talked through in a consultation? Do you want the paper? What do you want? And we were able to tailor the information we were giving to the patient, to the patient's needs, that whole thing of informed consent, informed information around how you are, what is wrong with you and how you are going to be cared for. We met the patient at their point, at what they needed. One of the things I feel concerned about is actually how do we do that within the NHS app? Because actually we could have people having information that is misleading or gives them something that actually they didn't want to know and they didn't want to know at that point in time. And I think bringing this back to the patient, and this is about the patient's care, the patient being safe, us giving that brilliant high quality care to our patients, is where we all come back to.
Yeah, and that's why we're doing this in stages and slowly, Emma, because I don't think we have all the answers to that. But a digital assistant for the patient where they can ask and actually get more and more information is probably the way forward to that. But we'll need to test that, and we need to do, lots of testing with the public as well.
We are unfortunately in the last 5 minutes already. Well done, everybody. So I'm going to come around for kind of last 30 points that people would like to share. There are quite a few kind of questions on here. We've answered most of them, but I think people are looking for that. Where's the clear roadmap, Ming? And can we start tomorrow? We're not quite there. But one thing I think Ming has been fairly firm on is that it is a modular approach, and best practice will be taken, or good practice will be taken. It's not a invent it here syndrome, although there obviously will be a lot of that where some of the process doesn't exist. So I just want to cater for quite a few of those questions that are still on that kind of point. But Lee, can I come to you first for your sum up points and any final comments you have, please?
So my final points are, we've got to remember this is around people and patients, and we're only there for their needs, and not forget that fact. And also, based on that, we've got to also remember this is around changing culture, which is really hard, whether that's changing culture of how we work together digitally or how we work professionally, whether that's the single patient record, the existing Concare. So let's keep that focus on the patient, and let's keep trying to improve that quality of care.
Lee, perfect. Basil, can I come to you, please?
Thanks. Well, I welcome the offer, Ming, because I'd love to chat about things. I think we do need a skunk works. We had one in NHSX that never really did that. I think it needs to be small. It needs to have the right range of expertise and free from the immediate priorities to inform what we're doing right now. But also, maybe it's the 100-year plan. I know that sounds really stupid, but my patients will live 100 years potentially. And I do think about what the consequences of day one actions are for their 100-year lifetime. And I sometimes talk to them about it. If there's a space to do that, that will need to be above the NHS. I've been doing work with the PRSB that supports NHS Commission, worked on the canonical data model. The fact you're bringing people voluntarily to do that work and people want to do it is the problem, because we're not supporting those very basic questions that will inform everything. So I think we should do that in parallel, and I would strongly encourage people to support, call for it, and let it just happen quietly on the side.
We actually used to run a Skunk Works as part of EHI Live, and there's been a bit of a discussion about whether we bring something back at the moment, particularly with Open Air and a few other organisations, but I'll leave that for another day. Ian, can I come to you next, please?
I think it's the simple point I've made throughout of the importance of seeing it as part of a wider system, and the codependency, and also the opportunity that exists through working in that way. Things that may not be realisable in isolation within the NHS are more realisable. For example, we talked about the focus on the harder to reach customers digitally. That's where local governments are. They are very much improving the digital infrastructure so as to enable the time to be spent with those people we have to reach out to, expanding those community contact points across the whole city to support that work. So rather than building something akin to that in the NHS, relying on what exists in local government to support it, I think it would be sensible.
Thank you, Ian. Emma, can I come to you, please?
Lee pretty much stole everything I was going to say, so that's not helpful. So I guess what I would say is what we need to always be coming back to is patient-centric, clinician-centric. Whatever we're doing has to work and has to work for those people who are using it day in, day out. There is a clinical practice, there is a clinical process part to that. There is a cultural change. We need to remember our patients as well and make sure that whatever we're doing, patients have their control and their autonomy in it as well.
Absolutely right, Emma. Thank you. Ming, your final comments, please.
Okay, so I would say that even though I hate the name single patient record, it is a once in a generation kind of opportunity for us to connect up the NHS and be patient centric. You know, it will overturn a lot of our problems, I think, if we get it right. I don't want us to think about it as about a technology. It is about a way of working. It is about an enabler for transformation for all the way that we deliver for patients and our clinicians and other parties that are really working with the NHS to do the right thing for the population at local level. It's a capability, it's not a platform. And as I said, you know, there's going to be modules that we will buy and we will curate more modules for use cases. It's really important we don't lose the public trust as we go along. So the governance privacy will make things a bit clunky. We need to really bear in mind, as Basil says, the clinical safety aspects of single patient record. And particularly if we draw AI into this, we're going to need to kind of work that through. And this is why we're taking our time. And then we're trying to work as openly, as collaboratively as possible. So if you don't think we are, come and tell us and let's have some conversations about how we can do this. It's almost, you know, it's a darling of the system, but it's also, it could be, as I said earlier on, you know, it could be quite ugly if we don't do it right. So let's get the right things, the right input into it.
Yeah, and I'll just use that to emphasize that last point there. Everyone wants the answer. Everyone wants a roadmap. If this is how it's going to be done, it's going to start tomorrow. This is what it's going to look like. I think one of the things that everybody on this call is trying to do here is make sure that the work that is done here gets us towards a better solution rather than just a solution. So we don't have all the answers yet, but we are working for better answers. So we will continue to run these series. We will ask Ming and her colleagues back again, along with our other colleagues, as we develop and this goes further, so we can actually give more insights as we build on this. But really appreciate all of your time, everybody, and thank you, the audience, for joining us as well. Take care. Have a lovely weekend. I'll speak to you all soon. Bye bye.
Thank you.